All right. Thank you everyone for joining us. My name is Maggie Dish and I am ACC staff for the Geriatric Cardiology Section. And we would like to welcome you to the Geriatric and Interventional Cardiology, Finding Intersectionality Through Case-Based Learning. This is brought to you by both the Geriatric Cardiology Council and the Interventional Cardiology Council. Just a quick run through of the agenda for today's webinar. We'll do some brief introductions, talk about FIT and early career opportunities, go through 2 case-based presentations, followed by discussion, question, and answer. Please use the chat box throughout the webinar to ask questions to our speakers and panelists, and we will get to as many of those as we can, either through chat or we'll ask those questions through the audio at the end of the webinar. Also, don't forget to tweet at ACC in Touch and tag hashtag ACC Geriatrics and hashtag ACCIC. Our featured speakers for today are Dr. James Kirkpatrick, who is chair of the Geriatric Cardiology Council, Dr. Wayne Batchelor, who is a council member of the Interventional Cardiology Council, as well as being a member of our Structural Heart Disease Collaborative Work Group, Dr. Gwen Bernacki, who is a leadership member in the Geriatric Cardiology Section, as well as being a member of the Structural Heart Disease Collaborative Work Group. And then lastly, Dr. Abdullah Damluji, who is one of our new FIT Early Career Leadership panelists. Additionally, I'd like to list off our panelists for today's call, who are a nice mix of our geriatric cardiology leadership and interventional cardiology leadership: Dr. Karen Alexander, Dr. Ashok Krishnaswamy, Dr. Gwen Bernacki, Dr. John Mulrow, Dr. Janet Wyman, Dr. Radmila Lyabarova, and Dr. Fred Wells. So to start off the call, I'd like to turn it over to Dr. Jim Kirkpatrick and to just get a little discussion going with Dr. Wayne Batchelor. Jim?
Thanks so much, Maggie. And welcome, Wayne. We really appreciate you being here. I do have to say, I think a lot of people would think this is a bit of an interesting intersection between geriatrics, a sort of a specialty that's about sort of thinking about the whole person and being very cognizant of some of the things that are not sort of traditionally in cardiology, and interventional cardiology and structural heart disease, which is really about doing procedures and getting things done quickly. I wonder if you could just comment on sort of what some people might see as a bit of a disconnect in our 2 groups coming together. Do you see that that's a disconnect, or do you see these 2 things actually finding some common ground in the care of patients?
Well, first of all, thanks, James, for the opportunity to speak to you and others today on this webinar. And thank you for American College of Cardiology for this opportunity. I think it's long overdue, this discussion. You know, there's been pretty good technological advance in interventional cardiology. I think we're very proud of the accomplishments that we've gained over the last 10 to 20 years, especially in the structural heart disease realm, complex multi-vessel PCI, chronic total occlusion interventions. Where I think we've missed the boat is exactly in the arena to which you're referring. And that's the intersection between understanding what we should do versus what we can do. We can pretty well put a valve in almost any human being, in almost any type of situation. The question is, what is appropriate for that patient, and how is that really going to impact their long-term their longevity, their prognosis, and most important to the patients, how they feel, how they function, and how they get through their day-to-day activities and their quality of life. It's those latter factors that I've just mentioned where I think we as interventional cardiologists have gotten over our skis, and we're sort of technologically advanced, but perhaps cognitively a little bit behind. And I hate to admit that as a structural heart disease interventionalist, that'll probably come back to haunt me. Michael Mack and Marty Leon will probably be calling me shortly. I do think there's an opportunity here. So, I think this is a great seminar and webinar because more than ever before, we need geriatric medicine. We need to understand frailty, risk, how to incorporate patient-centered decision-making, health values, and what we do can affect so many aspects of an older patient. We have to get our head around it better. So I welcome this opportunity, and I think it's long overdue.
Wayne, I'm really glad we're recording this seminar because I definitely couldn't have said that any better. That's absolutely wonderful. It does strike me that we have many things that we can do for patients, many interventions that really can focus not only on longevity, but also on making patients feel better. Do you think that there are a lot of difficult situations in which we're, interventional cardiology in particular, in which we're sort of pitting the life prolonging versus the quality of life improving type of situations? Or do you think actually there's a lot of common ground between what you're able to do for patients in terms of those issues?
Yeah, I think, first of all, there is common ground, Jim. I think that at the end of the day, we're out to help the patient, help them live better and live longer. Where we miss the mark, in my opinion, as interventional cardiologists, we just simply don't have the tools, the education, and the insight to really understand how to evaluate a geriatric patient. And this is where we have to lean pretty heavily on geriatric specialists. We can understand how to get the valve in, but what's really important to us is how is that patient going to benefit, and is the risk of the procedure worth the damage? That benefit may be an improvement in quality of life, maybe a prolongation in life, or maybe some independence. But the reality is some of the things that we do can also compromise those valuable things that are important to patients, like their independence. And if we make them worse and they're on a slippery slope, obviously we can cause more harm than good. So what we need help with is understanding the real recoverability of the patient. We have to understand what matters most to that patient. I admit I had to do a little bit of background reading before today, and I was just looking at some of the geriatric papers that have come out, and I think, Mary Tonetti at the Canadian Geriatric Society meeting coined the 5 M's, and I think that's becoming more popular nowadays. The concept of mind, mobility, medications, complexity, and then what matters most for patients. And I think we as interventional cardiologists are able to understand those concepts much better when we intersect with people like yourselves and others in the geriatric field who really understand how to navigate through these complex issues very well. We need better futility indices to understand when is it time to say no. There's a lot of therapeutic momentum that builds up, and by the time the patient has seen us, the family, the patient, and a lot of others have huge expectations. And we don't want to be the ones to turn them down and say, you're destined to basically die of aortic stenosis or mitral valve disease unless we really feel that that's right. And we need some help in making those correct decisions.
Oh, that's a great point. It sounds like what you're advocating for is an expansion of the heart team a little bit to include the geriatric cardiologist, perhaps the palliative care cardiologist. And it certainly sounds like, if you don't mind the pun, a new partnership that might actually need to be taking place to provide the best quality of care for patients.
Yeah, I think this goes without saying, James. I've learned so much over the last year in particular by simply getting some geriatric consults and working directly. We're going to talk about this a little bit later on, and Dr. Damluzzi has some great slides and some good case examples of this. But we routinely incorporate a geriatrician and also palliative care in our valve clinic assessment of patients in whom we feel there would be incremental benefit. And so a good number of patients over age 75, especially those who have a clinical frailty score of 6 or greater, it's just a knee-jerk thing where they automatically get comprehensive assessment from the geriatricians. So the multidisciplinary heart team is changing. It's changing over time, and it should. It should be malleable. There should be some definite people who are on that team, obviously a cardiac surgeon, an interventional cardiologist, and APPs, and nursing staff, et cetera. But we need to be able to lean on, when needed, geriatric specialists, people who understand frailty, futility, quality of life, functionality, and cognitive impairment better. We need to pull those experts into the multidisciplinary team on an ad hoc basis so they can bring to bear their expertise and help us make the right decisions.
Absolutely. And that's a great segue into our next section here, because it sounds like there's going to be increasing opportunities for involvement of geriatric cardiologists, actually not just at the structural heart and interventional side, but really all across the board. And there's no better person to talk about that than Gwen Bernacki. So let's turn it over to her to hear about some opportunities for fellows in training and early career professionals.
Thank you, Dr. Kirkpatrick. First, for anyone who is interested, please feel free to reach out to me or any of our panelists if you would like. Recently, we have a newly appointed leadership panel who's just superb. They've been assigned to work groups and will be working with senior leaders as mentors. Maggie, can you advance? Thank you. Now, if you aren't already a member of the Geriatric Cardiology Section, we have a link here, and membership is free for FITs. And we also have an opportunity for you to complete a survey to express your interests. The one thing I have learned over the years is that this group is very responsive to what your interests are. And I've seen a lot of my colleagues flourish with such mentorship. You can connect with our ACC staff liaison, or as I mentioned, with any of our panelists or myself. Maggie? As I mentioned, there are several work groups within the Geriatric Cardiology Section, namely the Palliative Care Work Group, which I'm heavily involved, the Research Work Group, ACC.org, and Advocacy. There are opportunities for mentorship in all of these work groups, and we also have some opportunities for research and funding. GEMSTAR is an award that is run annually by the NIA. And this cycle, this is the posting for this cycle. The goal of the GEMSTAR program is to provide support for early career physician scientists trained in medical and surgical specialties and early career scientists to launch future careers as future leaders in aging. If you're interested, look this summer for how to apply. And you can look at clinstar.org for more details. Next, as part of ACC's efforts with geriatric cardiology, they have aligned themselves with the George F. and Ann Harris Fellows Foundation to support cardiology applicants for the GEMSTAR Award. This is a $50,000 award over the course of 2 years. It typically accompanies a successful, or it can accompany a successful GEMSTAR. And the process is to submit a professional development plan and cover letter. So with that, I'm going to pass off to our other presenters for some wonderful case presentations.
Thank you, Gwen. Passing over the reins to Dr. Zemluji.
Yes. Well, thank you again for inviting me to present 2 challenging cases. My name is Abdallah Zemluji. I work with Dr. Wayne Batchelor at the Innova Heart and Vascular Institute. And my interest is in geriatric cardiology and bringing that geriatric risk assessment to the interventional cardiology world. And I've been working with the geriatric cardiology leadership since 2010, and it's been a really wonderful journey. These are my disclosures. I am funded by the NIA and by the NHLBI to study geriatric risks and in the cath lab and in the interventional cardiology world. And that highlights the interest of the NHLBI in geriatric cardiology and how we can develop our understanding about geriatric risk and about futility of care. So hopefully I will present these two cases about two different disease entities and how we assess geriatric risks and how we made decisions whether or not to proceed with invasive cardiovascular care. And I would we'll do this with Dr. Batchelor if Dr. Batchelor wants to interject and give comments. So the first case study is an 80-year-old gentleman who was a former economist at the IMF who lives here in Washington, D.C. He presented to our institution with angina pectoris and both at rest and on exertion, and had recently had multiple falls and inability to keep his posture and inability to walk. His cardiovascular risks include active smoking since he was 15 years of age, has hypertensive heart disease and dyslipidemia, but no history of diabetes mellitus. He had history of peripheral vascular disease with abdominal aortic aneurysm with endovascular percutaneous intervention in the past. And with the intervention, there was a contained 8-centimeter abdominal aortic aneurysm currently. He also has a right superficial femoral artery angioplasty and had below the knee disease quite severe. He has anemia of chronic disease, obstructive lung disease, history of Crohn's disease with intra-abdominal surgery. And the point of listing all these past medical history is just to highlight that this older adult has the stereotype of multimorbidity who presented to the hospital with a cardiovascular complaint later found to be non-ST elevation myocardial infarction. On his physical examination, his hemodynamics were stable, but he had an increased venous filling pressures with an elevated jugular venous distension. He had an S1, an S2, and S4 indicative of a diastolic dysfunction, had wheezing on his auscultation of the chest, bilateral pitting edema, as you see in the picture here. And he looked, if we assess frailty just by looking, which I learned later on not to do this, but he looked frail and sitting in bed. His EKG did not show the sinus rhythm with PACs and no Q waves and no ST segment changes. His echocardiogram revealed a normal left ventricular systolic function. He has a grade 1 diastolic dysfunction and elevated filling pressure, and his cardiac enzymes were mildly positive, peaking at almost 1 nanogram per mil. So because of the diagnosis of non-ST elevation myocardial infarction, he was referred to our team for a cardiac catheterization, which was done through the right radial artery to minimize his risk of bleeding. And this is his angiogram in the AP caudal view, and I tried to put some images here so that, you know, we highlight the interventional cardiology work as with the geriatric work. In the AP caudal view, you see there is an eccentric, heavily calcified lesion in the distal left main coronary artery at the bifurcation. In AP cranial view, you see that how eccentric Medina 1 classification and the proximal side of the lesion, and that lesion extends into the LAD and the circumflex coronary artery. Further, this is a REO cranial view showed that eccentric, heavily calcified lesion with TIMI3 flow in the LAD system, and the right coronary artery had moderate calcific, non-obstructive disease, and maybe moderate to severe disease at the bifurcation into the RPDA and right PLV, right dominant system. His LV-gram showed a normal left ventricular systolic function, and through the wrist, we advanced a pigtail catheter and took a picture of his peripheral vascular intervention, and you can see that there is more or less patent endovascular grafts. So, as Dr. Batchelor was alluding to in the beginning, all of our patients get a clinical frailty scale just as a screening method for frailty. And if we go through the clinical frailty scale, this patient falls at moderately frail, and whereas he will need help outside his normal activities and with keeping up his instrumental activities of daily living. If we review his geriatric history and we go back to his primary care physician's note, he noted difficulty walking and the problems with his gait, and also memory loss and cognitive impairment, and that was 5 years prior to his presentation to this hospital admission. And because he is above 75 years of age and he has a clinical frailty score above 6 or more, that would, in our institution, triggers a geriatric consultation prior to any invasive cardiovascular procedure if the patient is stable and is not in active substernal chest pain or is in discomfort. As such, a comprehensive geriatric assessment was performed, and that included a nutrition by using the mini nutritional scale. And using this scale, he going through this questionnaire, you would notice that his scale falls between 8 and 11, and he is at risk of being malnourished in the future as when assessing his nutritional status. Assessing his functional status, looking at the CATS ADL score, you see that he was, prior to admission, completely independent in performing his activities of daily living, like eating, bathing, dressing, and transferring in and out of bed and toileting. However, he had impairment in his instrumental activities of daily living, where he was reporting problems handling his finances and handling his medications that were, and he receives assistance from his wife. So while he is functionally independent in terms of his activities of daily living, a more subtle impairment is detected by screening for his instrumental activities of daily living. While he was in the hospital, we performed the CAM score, and he was cognizant, he was with it, and he did not have any active delirium. We actively screened for benzodiazepines, for other deliriogenic medications, and in older adults, we try our best not to administer these medications, and this patient went into the cardiac cath lab without being labeled as delirious. Now, when assessing his whether or not he has depression, we ask these patients the geriatric depression scale, and if you can see how he scored, asking him a question about whether he is satisfied with his life and whether he has dropped interest in many of his activities as a result of his multimorbidity and as a result of his symptomatology, whether his peripheral vascular disease or his overall health. He is indicating impairment in several of these questions, and having 5 of these questions positive would label him as being a geriatric depressed patient. Now, looking at his medication list from the outpatient setting, I can just highlight some are psychiatric medications, and some are secondary cardiovascular prevention medications. And these, just looking at his list, he also has polypharmacy. Now, assessing his environment, we thought that the environment is safe. He was living with his wife and his dog. However, he was labeled as a fall risk, as he was not able to perform the get up and go test. Now, his mini mental state was 30 out of 30, and we engaged the geriatric team to making an assessment on whether or not we should refer him for an revascularization, whether it's percutaneous or surgical. Now, assessing his mental status, as I said, we asked him to draw the time and to assess whether the subtle problems with his cognitive function, and he was able to label to draw the actual time, but as you can see that he made some mistakes. So this subtlety in his cognitive function was detected while doing his comprehensive geriatric assessment. On imaging, he has this peripheral vascular disease that I'm not going to go into in detail. He was found as part of this assessment prior to any intervention to have left carotid disease, and his endovascular grafts were found to be patent in case a left ventricular support device was needed. Now, in assessing his overall risk, this is a 79-year-old man who has multimorbidity, a lot of cardiovascular risk. He is frail, he has polypharmacy, functional decline, who presented to the hospital with non-ST elevation myocardial infarction. Now, his syntax score is high, is 56. His syntax 2 score shows a very high risk for long-term mortality, and his STS score shows a immediate risk of 12% of mortality. And he was evaluated by our surgical colleagues and was declined for surgical revascularization. As such, we, by the recommendation of our geriatric team, we were able to proceed with percutaneous intervention. And just to go quickly of how we approach this case, we use a distal right radial artery where, with ultrasound guidance to reduce the risk of bleeding and to preserve his radial artery. And you can see here, this is the ultrasound machine. We scan the radial artery in relation to the radial bone, and then we get access under ultrasound accurately so that we do not cause any excessive bleeding in this older adult with underlying anemia and an increased risk of bleeding given his multimorbidity, polypharmacy, and his higher risk of bleeding. And as you can see here, we're trying to access his distal right radial artery using a micropuncture system under ultrasound guidance. We put a 6 French sheath in the distal right radial artery, and we obtained access into the right femoral artery by putting a micropuncture wire in the right femoral artery and leaving that wire in place without dilating it with micropuncture or with any sheaths in case the patient develops hemodynamic instability and we have to use a left ventricular assist device. But this was not used in this case. The procedure itself was, as you can tell, is complex and heavily calcified left main lesion. The lesion was pre-wired with 2 extra support whisper wires, and I'm sorry I'm going into details in this, but this just to show the interventional folks that these patients are not only complex from their overall state, but also from their technical perspective. We have an over-the-wire balloon here trying to cross that left main lesion. We ballooned that left main lesion prior to advancing any devices. And then we pulled the LAD wire and exchanged it to a rotational atherectomy wire, extra support, and we did a rotational atherectomy through the circumflex coronary system. We did a kissing balloon inflations in the left main system. And I'm sorry I'm going this a little fast in this, but after we were doing, while we were doing this procedure, we have discovered that there is a distal perforation in the LAD system. As such, we have ballooned this, the distal LAD. Dr. Batchelor and myself and others, we ensured that there is no pericardial effusion. We deployed a microcoil through a microcatheter, and we stopped that bleeding. We stented the proximal into the mid LAD. We stented the mid circumflex coronary artery, and then we performed a mini crush technique and performed complete revascularization to this lesion. This is a proximal optimization technique and under IVUS guidance, and these are the final images of how the patient did from procedural perspective. He had complete revascularization to his left system, and there was no distal bleed. At the end, we have performed a safeguard hemostasis device to achieve hemostasis to his right distal transradial access site, and hemostasis was achieved, as you can see in here. And then post-procedure, we obtained an echocardiogram that showed a normal systolic function with no pericardial effusion. The patient did actually very well. He was stable the next day. He was discharged to the hospital, was seen in the clinic by myself in 2 weeks, and at 3 months interval, the angina has completely resolved. There was improvement in some of his instrumental activities of daily living. And this just highlights how the assessment of his physical, functional status, his cognitive status, his environment, and his risk of falls can be integrated in the decision-making of an interventional procedures. On the long run, I have simplified his medications, and actually now, almost a year out, I have discontinued his Plavix, and he's currently only on baby aspirin. As you can see, a multidisciplinary approach of geriatric assessment and interventional cardiology are complementary in looking at a patient as a whole. Now, I'm going to just go through the second case, and she has...
Abdullah, before you go on, I mean, wow, that was something else, first of all. Thank you for that case description. I think you presented basically a textbook of interventional cardiology and a textbook of geriatric medicine all in one case, it seems. And I just wonder if there's an opportunity here to pause for just a moment, because there's so many issues with that case that raise some really good discussion points. Number one, the complexity of these evaluations. One of the reasons, James, we need geriatricians is we had no idea the level and degree of limitation of this patient. He was an economist. He was the smartest person in the room, I thought, Abdul, when we were talking to him. Maybe that's not saying much, but he was with it. This guy was sharp on the appearance. He spoke well. It seemed he was articulate. You got the impression that he was cognitively intact. But when we started to do a deeper dive, there were some, there was an element of degradation of cognitive function that I think would only come out with sophisticated testing. Number two, the testing is difficult. It takes time, and you have to know what you're testing and what the results imply. Interventional cardiologists, we don't know that. No interventionalist is going to take the time to do all that you described. And that's the second reason why we need experts to come to the bedside to help us. Third thing is, we are exposing these patients to tremendously risky procedures at times. And for them to be able to garner the benefit, we have to understand that they are recoverable. In other words, their rehabilitation is going to be smooth, and they'll get to a better point after perhaps taking a step backwards. They'll take 2 or 3 forward. And it's very hard to assess that, and I think that's where geriatric medicine comes into play. Let me ask one quick question, and maybe I'll open this up to the panel, because I'd like to hear from other folks as well. When we deal with these patients who have multi-comorbidities, cognitive impairment, physical impairment, polypharmacy, and coronary disease, how do we unravel and understand if we treat the coronary disease that they're going to get better? I mean, that's the holy grail here. And all these tests, this patient really didn't fare very well. Why is it that we did the procedure in your mind, and perhaps in the panel's mind, and what would help us understand how to make that proper decision for this patient? And maybe we can just back that around. I see Janet Wyman's on the call, and Gigi's just a phenomenally bright practitioner who's really led the way in helping understand the role of the multidisciplinary team. Can we pick on you, Gigi, and help us understand, how do we sort through these complicated patients and understand the ones that we know we can get through the procedure, but how do we know the ones that are going to actually improve? And then we'll ask the geriatricians to speak up.
Yeah, thanks for that kind introduction. Dr. Demelucci, this is a great case. I was very impressed at the geriatric assessment and that knowledge that you had, or that information that you had called out on his history. There were some things that struck me. I was looking over his depression scale, and that's what really jumped out at me, that there were hints there in his depression scale that said, if we could pay attention to this, yes, you have to do the intervention, because none of the rest matters if he's not alive. But once you get past that point, and this is a great case that underscores why, you know, I've been in the interventional world for probably my entire career, and the issue is take care of the patient, but then moving it on in your team and knowing that you have built that team to address it. The depression scale is the one that really jumped out at me. If he's not doing things that he at one time enjoyed, why? Because everything else seemed to fall into place after that. We know that when we take the keys away from our elderly patients, their mortality rate skyrockets. It increases dramatically. And so that's what struck me. You expect a decline in motor function, but as we get older, that didn't jump out at me as much as the depression scale. So that's what I was focusing on. He had a good mental exam. You said that in your conversation with him, he was the sharpest person in the room. But we know that people who are depressed, they step back from life. So maybe understanding why he wasn't as active. Does he not have social support? That wasn't there, at least as I culled through the documents. I didn't see who was in his life. How is he getting out? Does he have opportunity to be exposed to other people? I think we've all learned in this COVID environment where we're all more restricted in who we interact with. We are all craving. Could we please have the opportunity to go to a meeting where we can again interact with our colleagues, and we're feeling it ourselves. So in his situation, those were the things that kind of jumped out at me.
Go ahead, James.
Well, Gigi, I just think you highlighted the fact that, you know, there was an opportunity taken here to improve his quality of life that was even beyond the intervention. Mm-hmm. And I think we always have those opportunities. And I think that one of the ways that probably his life was improved actually was in simplifying his medication regimen. And I was wondering if Ashok could speak a bit to this concept of deprescribing. You have to unmute yourself, Ashok. There you go.
Hi, Abdullah. I think that was actually an absolutely fantastic case that brought together the interventional point of view and the geriatric point of view. And yeah, I think, you know, one question I want to ask is the amount of geriatric instruments you've used is actually incredible. I was wondering who does it and when. That's one question. And in terms of the polypharmacy, that is the world that I think currently, if we start preaching deprescribing, it's almost a heretic view on this. So I think that science is actually going to have to improve over this time. And you'd be surprised that, you know, taking away medications appropriately, and there's actually a manner of doing that in older adults, often has the opposite effect of actually improving their functional outcomes. Beta blockers, for example, and Mike Steinman's work and others from this group have shown that they actually cause a lot of functional decline. And so we really have to be cognizant about the whole point of beta blockers and medications being a double-edged sword and use them in an appropriate kind of fashion. But the science of deprescribing is in cardiology at least, is truly in its infancy, and I'm really looking forward to seeing that, you know, exponentially grow.
Yes. So just to answer your question, Dr. Krishnaswamy, when I expressed my interest to Dr. Batchelor in geriatric cardiology in the cath lab and how to assess geriatric risk, he brought together the geriatric team and say, hey, can we work together in assessing risk? So in our institution, and we have certain triggers. We cannot, you know, burden the geriatric team to see everyone, but especially those with high risk interventions and those who have a certain age cutoff. In our institution, we set it at 75 with a clinical frailty scale of 6 or more. That will trigger a geriatric assessment, whether it's an inpatient setting or whether it's in the outpatient setting, and for example, in more elective procedures like the structural heart disease team. And maybe I'll just cycle back to Dr. Batchelor if he has a comment, and just for the sake of time, I'll go with the second case after, so that we have a contrasting view of how things can be when the geriatricians don't agree with an invasive care.
Yeah, I think we should forge ahead. I mean, we don't have a lot of time, and there's just so much more to talk about. I see some phenomenal people on the panel I think everyone's going to want to hear from. So why don't we do the second case and try to have some time for discussion.
Fabulous. Okay, so I am going to present the second case. So this patient is actually younger, so that will speak about, what's a phenotypic age and what's a biologic or physiologic age. This is a 76-year-old woman who was a former teacher. She lives in Washington, D.C., and she presented to the hospital, to our institution, with shortness of breath, and she was residing in a nursing home. She was on 2 liters of oxygen, and now she's on 6 liters of oxygen, and that's why she was transferred to the inpatient setting. She has cardiovascular risk factors, again, hypertension, dyslipidemia, and she has an insulin-dependent diabetes mellitus. Interestingly, she was admitted 2 months prior to her current admission to another hospital in Washington, D.C., with acute decompensated heart failure. And she was diagnosed with moderate to severe aortic valve stenosis. And because she continues to deteriorate, the structural heart disease in that outside hospital tried to do a palliative balloon aortic valvuloplasty. And post-valvuloplasty, her mean gradient is still on the higher side, is 36 millimeter mercury, peak gradient is 58 millimeter mercury with a dimensionless index of 0.24. During that hospital admission, she deteriorated even further. She required, her chronic kidney disease became end stage, and they initiated dialysis on her. She has underlying anemia of chronic disease. She had a normal left ventricular systolic function and a grade 2 diastolic dysfunction. She has a remote history of breast cancer that has been treated, and a recent diagnosis of monoclonal gammopathy that has been followed by hematology. Also, same profile, older adult with multimorbidity and cardiovascular risk factors. So I spoke with the daughter at length after I tried to get a sense of how the patient was doing 2 months ago, prior to her outside hospital admission. And she told me that she was relatively independent. She had no physical dysfunction. She was able to walk and do her things. And I tried to question her about her ADLs and IADLs, and as much as I can, she is telling me that she was fully independent. She was at her baseline nutritional status, and she was mentally sharp and had no cognitive dysfunction. She had no history of falls, and she was living with her daughter, who was the main caregiver and supporter of the family. So that was 2 months prior to this current admission. So during this admission, she had an echocardiogram that's a parasternal long axis view that showed a left pleural effusion and a collapse of the lower lobe of the left lung, had a normal left ventricular systolic function with a left ventricular hypertrophy, heavily calcified aortic valve with restricted leaflet motion. Color across the aortic valve did not show any evidence of severe regurgitation. A Doppler assessment showed a grade 2 diastolic dysfunction, and a Doppler assessment across the aortic valve showed moderate to severe aortic valve stenosis. This is after balloon aortic valvuloplasty, and the estimated aortic valve area was less than 1 centimeter square based on the continuity equation. So now we were called as a structural heart disease team to assess this patient and what to do with them. And again, I'm going through the same algorithm, and I'm sorry, this is seems repetitive. But if you look, I see this older adult in bed, completely dysfunctional, can barely sustain a conversation with me, and according to the clinical frailty score is an 8. So her score was an 8, and we discussed her in the structural heart disease meeting, and we decided to follow our protocol and get the geriatric assessment again. Now, currently, and after this 2-month admission, she had dysphagia as a result of her acute illness, and a PEC tube was inserted for nutritional support. She was not able to swallow, and going through the nutritional questionnaire, she has less than 6 points, and that indicates that she is malnourished. And actually, according to the geriatric assessment, she has high risk for aspiration as a result of her dysphagia, and they were cautioning the team on introducing fluid without further assessment to her swallowing ability. In terms of her functional status, both the ADLs and IADLs, she was completely dysfunctional and dependent on care by others, while for now almost 2.5 months. In terms of her cognitive status, I did the RAS and CAMS test myself, and was repeated by the geriatric team. And the patient, according to this, while she is oriented to time, to person and place, and she was not oriented to time, she, according to the questionnaire, she was actually delirious. She has polypharmacy, and because of her cognitive status, I was not able to perform the depression scale on her. As I said, she is bedridden. She's not able to get up and function. And currently, she's living in a nursing home where prior to this, 2 months prior, she was living with her daughter and doing her assessment. And we did the Fried phenotype, which is a test to more scientifically assess the geriatric syndrome frailty as a construct. And you can see this was done by the geriatrician, and the patient had a score of 3 out of 5, which actually labels her as frail, as you can see. The geriatric team commented on her gait instability, on her risk for constipation, and they also, by examination found that she had a pressure wound because she was in bed for more than 2 months, and she has, polypharmacy and at risk of medication adverse events as a result of the treatment administered during her hospital course. She had a heart failure and bilateral pleural effusion and collapse of the bilateral lower lungs. On further imaging, she had severe vascular disease, and that makes us think, and from a structural heart disease perspective, on alternative access, whether or not we can do, we cannot do femoral access because of very small femoral and iliac vessels that you can see, and advancing a transcatheter therapies through the femoral artery becomes prohibitive. As a result, we were talking about alternative access like a carotid access or intrathoracic access like aortic or apical access. And here we came again to the table and we spoke with the geriatric team. And, we said, as Dr. Batchelor was saying early on, we can put a valve in almost everyone, through their neck or through their aortic access or apical access, but would that reverse all these complexities, geriatric complexities and intricacies in this patient? And the geriatric team, suggested to proceed with palliative care, and this was with the palliative care arrangements to keeping the patient comfortable and controlling her symptoms to the best of our ability and not expose her to any invasive care. And that's what we followed. We followed their recommendations. And just to close, I work with Dr. Dan Foreman, Dr. Alexander on the panel, and other interventional cardiologists and leaders in the field on understanding these geriatric complexities and risks and during acute cardiovascular illness, and as a statement. And as you can see, these geriatric risks that we're going to talk about and discuss furthermore there's a lot of interplay between these geriatric syndromes and how they affect the overall health of an older adult. A younger adult gets an acute cardiovascular illness, they get treated, they go back to their baseline, while an older adult, get detours in terms of their, geriatric syndromes. And even if they receive guideline-directed medical therapy, they go below what they were at prior to their acute cardiovascular illness. So with that, I will just open the floor for questions and comments from the panel. I'm just presenting the other aspect of how geriatric assessment can be used in not to proceed with invasive cardiovascular care.
Great, that was a phenomenal presentation. I'd like to turn to Karen Alexander and for some comments on that.
Hey, yeah, Abdullah, that was just a phenomenal presentation. And the two things that I think are going through my mind is obviously, as Wayne said at the beginning, there's a difference between what we can do and what we should do. And obviously here, that was pretty clear. But the other flip side of that is that we're not doing nothing. We're not abandoning this patient at all. And that's a really important concept, I think, when we don't do a procedure, to make it clear that we're not doing nothing. We're just not doing something that's going to cause harm or is futile in this case. And then the other thing that I'm thinking about is, gosh, at Duke, for example, it would be really hard to get a geriatric team to come and do assessments. We just don't have that many geriatricians. And so I think the other message is that we kind of all need to know the basic constructs that you've laid out. I mean, the clinical frailty scale, the Canadian Cardiovascular Frailty Scale, is pretty simple. Drawing a clock is simple. And I think all of us, have a geriatric mindset that we need to carry with us, no matter if we're trained in geriatrics or not. We're caring for these folks, and this content matters a lot.
Yeah, that is a great point. Really important to remember. Any other panelists' comments on the specific case?
I'd like to bring up aspects of the palliative care. The second case was incredible. I mean, I'm a retired interventionalist, now burgeoning geriatric cardiologist, and I mean, the case is incredible, but the palliative care input was great. I mean, the palliative performance scale score on this individual was probably less than 30, so it was a right decision. On the first case, I was wondering, was palliative care invoked also? I know, as Karen said, we don't have enough geriatricians, we don't have enough palliative care physicians, but should all of these kind of complex cases have some input from palliative care? Because all of these procedures, whether we do them or not, are palliative in nature. So I was just curious, based on the manpower shortages, how one approaches that. But again, the heart team has to be enlarged to what we were saying in the beginning of the geriatrician and the palliative care approach.
Yes, I think I'm just going to give a brief comment on this, but yes, we understand they have limited time, and that's why we're very selective in involving them. However, we really value their approach to care. We're looking at the patient as a whole, and when we are trying to come up with some sort of a system in evaluating patients at high risk for cardiovascular intervention, we decided, okay, who is the highest risk? Older adults above 75 with multiple chronic conditions with frailty tend to have higher geriatric risks. And we said, okay, we need to find a quick and easy screening tool, which is the clinical frailty scale, and a age cutoff. And sometimes we add STS risk in the structural heart disease clinic. And based on these three parameters, that triggers a geriatric consult. Now, whether or not to involve a palliative care team, we are selective because of limited resources, but based on the recommendation from the geriatric team, we follow their recommendations on involving them early rather than late. And I'll just yield to Dr. Batchelor, see if he has any additional thoughts.
you know, it's not my area of expertise, honestly, but John, if I were to answer your question, I'd say we're grossly underutilized. They are phenomenal. And what I think Aaron Alexander hit the nail on the head. That second case, when we first approached that case, there was a huge thrust from the daughter to get this patient a valve. She said, can't we just put one of these new valves in her? I think she's going to get up and get better. I think it's all her heart. Well, we had a family conference with all of the specialties, geriatricians, the geriatric team, palliative care, Dr. Gamlucci, myself, et cetera, the hospitalists. And as Karen Alexander so eloquently pointed out, we turned it around to say, we're not giving up. We're just trying to marry the intervention with the appropriateness of the situation and the prognosis. And at the end of that discussion, it was amazing how the family and the daughter, you know, appreciated that. And then the palliative care folks took over, and she ended up, you didn't say what happened, she actually ended up going into palliation and died within, a couple of weeks, I think it was. She didn't live for very long. But it was a good passing, and the family was able to pay their respects, and the patient was very comfortable. So that was the right intervention, and it was an intervention. So, John, I think we underutilize it. It's just a matter of human resource and capability of various healthcare systems. And we're blessed to even have geriatricians who can come down to the valve clinic and do these phenomenal assessments. I hope it lasts, because it's really phenomenal. One other thing I would say is it's important for the valve team and the interventional cardiology and cardiac surgeons, because, again, when we put a valve in and a patient dies 6 weeks later, it doesn't shine well on our program, and it's not good for the patient, it's not good for the family, but it's also not good for the program. I mean, we don't want to be doing these cases if there's futility.
That's a great point. Ashok, any comments? Looks like you're muted, Ashok.
I wanted to make one comment in this really two complex cases. Is David Rubin at UCLA, I think reading his work kind of taught me in terms of looking at disease-based goals and overarching goals. And disease-based goals is kind of the world we're kind of living in here, but overarching goals is actually kind of simplified. When I think of these complicated issues, I go, what do you want to get done? Basically, Mr. Jones, he would like to walk 100 yards with his wife and his dog every day. That's a very objective assessment and saying what he wants. And then I kind of go back and saying, how does a treatment actually, can it actually help him? Will it improve 50 yards? Will it improve? Are you going to suddenly do a half marathon? Where are we going to go? And then that starts, I think, a different conversation than what is kind of what Dr. Alexander and everyone is saying. We're not abandoning. We're trying to match the appropriate treatment with the patient and looking at specifically overarching goals. This is what I'd like to do. Then it makes it a little easier to kind of wrap our brain of not abandoning people. We're basically not choosing all the tools in the closet because they're not actually applicable to this person.
Absolutely. Well, we are nearly out of time. I want to thank everyone for an absolutely wonderful time. I will say there's so many things that we didn't get to this evening. One thing in particular that we were hoping to talk about is, what do you do with a patient who's DNR and is going to get a TAVR? But we'll have to leave that as a teaser for a future event, perhaps. I want to turn it over to Maggie for the very last comments here. And again, thanks to everyone for participating, and especially to our panelists for an absolutely stellar presentation.
Thank you, everyone, for joining. Just to let you know, you can contact Abby Sistoni or myself. I put our emails in the chat about joining either the section or the work group, and then we will have this on demand on video as a recording for you available hopefully within the next few days. Thank you all again. Great presentations, great discussion.
Thanks, everyone. Good night.
Thank you guys so much. That was amazing. Truly fabulous. Wayne and Abdullah, you're going to be the basically the talk of the town in geriatric cardiology. That's an amazing thing that you've put together there, and it's a great example for all of us.
No, Dr. Batchelor should run for office, and no one.
Yes, that's exactly.
Pretty good. I think there's enough competition out there right now. I'm good. No, that was an excellent program, and geriatric cardiology has such a bright future.